Hello, everybody. This is Gul Muniz from Columbia University Medical Center in New York City. And on behalf of my co-moderators, Drs. Forghani, Bunch, and Kelly, welcome to the scientific paper session of ASHNR 2020. Please be aware that these are pre-recorded introductions and presentations, but each one of the moderators is here for the live chat. We highly encourage questions, comments, and discussions via the chat function, which we will be moderating throughout the session. So without further ado, our first presentation comes from Emory. Dr. Milind Patel will present a paper entitled CT Imaging Appearance of Active Extravasation into the Aerodigestive Tract as a Complication of Treated or Recurrent Head and Neck Cancer.
Greetings, everyone. My name is Milind Patel. I'm a neuroradiology fellow at Emory University. Today, I'm going to talk about dot in a slut sign, which is really an imaging appearance of the actively extravasated blood into the aerodigestive tract seen on contrast-enhanced CT. We have no conflict of interest. Radiation is commonly used in treatment for head and neck cancer in combination with surgery and chemotherapy. Radiation is a great tool, however, it's not without its downfall. Radiation can cause vascular damage and hemorrhage, which could lead to life-threatening situations, especially when it presents in aerodigestive tract. It is important for radiologists who's looking at this study to be aware of telltale signs and know where to look. To identify hemorrhage and its source, it is important to understand the anatomy of the external carotid artery and its branches. Here we have lateral projection view of the external carotid artery, TSA. The first branch off of the ECA is superior thyroid. The larger branch taking off posteriorly is occipital. Then you have two branches taking off anteriorly. The smaller branch is lingual artery. More tortuous and larger branch is facial. The smaller branch taking posteriorly is auricle. Then external carotid artery goes on to terminate as superficial temporal and maxillary branch. Here we have axial view of the neck showing the takeoff of the facial artery as it takes off laterally to supply the lateral face. The smaller branch anteriorly is lingual, which takes off anteriorly to supply the lateral tongue, as you can see here. We did retrospective report search of CT and CTA neck going back 15 years using keywords such as hemorrhage, hemoptysis, hematemesis, and extravasation. We use inclusion and exclusion criteria as such and compile the result on this table. As you can see, all of our patients had oropharyngeal cancer except one who had oral cavity cancer. Half of the patient had a disease recurrence at the time of hemorrhage, and half of the patient required treatment for their hemorrhage. We're going to talk about dot in a slut sign, which all this patient had. So here we have 74-year-old female with history of right tonsillar squamous cell carcinoma presented to the ER with hemoptysis. As you can see here, she had a disease recurrence within the right glossotonsillar sulcus going into the right floor of mouth. She had actively extravasated blood into the oropharynx surrounded by sludge of debris, which really makes this dot in a slut sign. She had a good amount of blood within the oral cavity, as you can see outlined by the red line. This patient required treatment for their hemorrhage. As you can see, right facial and right lingual artery was occluded at the time of this DSA compared to normal contralateral left side. The right superior thyroidal artery had irregularity, which thought to be a source of the hemorrhage. As you can see on the post-embolization images, right superior thyroidal artery was occluded with coils. Here we have 64-year-old female with the right retromolar trigonal squamous cell carcinoma presented to the ER with hematemesis. As you can see here, within the right oropharynx, you have dot of contrast surrounded by the sludge of debris. Again, dot in a slut sign. Layering of the actively extravasated blood within the oropharynx. And on sagittal and coronal images, you can make out dot in a slut sign. So you can use the sagittal and coronal images to look for the dot in slut sign as well. Here we have 54-year-old male with a history of squamous cell carcinoma of the oropharynx presented to the ER with hemoptysis. As you can see here, there is a dot of actively extravasated blood into the sludge of debris in the oropharynx. Same thing on axial images. You can see the dot of contrast surrounded by sludge of debris. On the right farmost image, you can see the linear density going into the dot of actively extravasated blood. The linear density is probably a lingual branch. This patient went on to have embolization of their left lingual artery. As you can see on the pre-treatment planning images, irregularity within the left lingual artery. On post-embolization images, you can see the coils within the left lingual artery. So here I have one more example. 67-year-old male with a right base of tongue carcinoma presented to the ER with hemoptysis. So now you can make out here there is a linear density going into the dot of contrast, which is again surrounded by sludge of debris. You can make out a theme here, dot in a sludge. And on the right farmost image, you can make out that the linear branch going into the actively extravasated blood. This is most likely a right lingual artery. This patient went on to have gel embolization of their right lingual artery. As you can see here, mid to proximal portion of the right lingual artery was irregular, which thought to be source of their hemorrhage. The right facial artery was occluded at the time of this TSA. The mid to distal portion of the right facial artery was reconstituted by collaterals. On the post-embolization image here, you can see that the right lingual artery is missing, which was embolized by gel particulates. Here are the treatment options. Note that the external carotid artery branches are more liberally embolized compared to internal carotid artery, given there is more robust collateral circulation within the face. So, in conclusion, it is important to get a CT with contrast or CTA as a first key step when evaluating patient with upper aortodigestive tract hemorrhage, and especially in a patient with head and neck cancer. Look for dot in a sludge sign. 6 out of 6 patients in our study had a dot in a sludge sign, which helps to localize the site of the hemorrhage. And at the end, look for a branch of the vessel that led to the hemorrhage. It is important for the surgical planning, and it will help out our neurosurgical and neuro-IR colleagues. Here are my references. Thank you very much for your attention. Feel free to email me if you have any question.
So that was a very nice presentation, Dr. Patel. Congratulations. And a really nice, very interesting group of cases. I guess my one question is, did you have CTAs on every one of these patients, or did you have some CTs and some CTAs? And I guess my second question would be, were you able to pick up the actual anatomy of the bleeding vessel on the CTA, as well as as good as on the angiogram? So was there a correlation between the CTA and the angiogram? Thanks.
All right. Yep, that's a really good question. So to answer your first question, a few of these patients were presented to our hospital from outside, so they had already CT performed outside, which were CT neck with contrast, and I believe one patient had a CTA. So it's a combination of CTA and CT neck, but majority of the patient had a CT neck with contrast. To answer your second question, I think even with the our protocol here at Emory, we can make out the anatomy of the external carotid artery branches going into the actively extravasated blood, as I showed in a couple of cases where which nicely correlate with the angiographic images, where the branches we thought that a most likely cause of the bleeding were to have like a some sort of irregularity or defect on a CT, actually angiographic images like DSAs.
Awesome. Thank you so much. I think we are out of time, so let's move on to the second presentation.
Thank you, Dr. Patel. Our next presentation is by Dr. Perçem Söylemez from Istanbul Medeniyet University Hospital in Turkey. Their presentation is entitled Accessory Maxillary Ostium, a Congenital Variation or Adaptation Mechanism, Importance of Reporting.
Dear Chairman and dear colleagues, I'm Dr. Perçem Söylemez from Istanbul, Turkey, Medeniyet University, Göztepe Training and Research Hospital. Today I will talk about our study. We considered accessory maxillary osteum. Is it a congenital variation or adaptation mechanism? Importance of reporting. Local Ethic Committee approved the study protocol. Accessory maxillary osteum has been reported 10 to 30% in cadaveric studies. Still, we don't know about is it a congenital variation, is it an acquired defect, or a perforation due to sinusitis, and are there any concomitant sinus pathologies with this osteum? At first step, 142 children, each between 1 and 10, included the study. Presence of accessory maxillary osteum and presence of maxillary sinusitis were investigated. On the other hand, paranasal sinusity examinations of 276 patients older than 15 were investigated. In second group, presence of accessory maxillary osteum, mucus retention cyst, mucosal thickening, maxillary sinusitis, septum dilation, concha hypertrophy, concha bullosa, primary osteum obstruction, snap process atelectasis, paradoxical concha, agernazy and Haller cells, maxillary sinus hypoplasia were noted. Patients with panorenosinusitis, polyposis, antrostomy, osinectomy, and turbinectomy defects with fractures in the maxillary sinus walls, in brief, destructed maxillary sinus walls were excluded the study. This is an example. You can see normal primary maxillary osteums in the same patient, right-sided, large defect in medial maxillary sinus wall, an antrocarnal polyp extending from this defect. In another patient, bilateral maxillary sinusitis, primary maxillary osteum is obstructed. You can see a small-sized left-sided defect in maxillary sinus medial wall. Two children, 8 years old, both of them, you can see right and left-sided accessory osteums. There may be more than one accessory osteums. This is an example. Normal primary maxillary osteums and right and left-sided osteums in the same patient. This is comparison results of children and adult group. This is comparison results of accessory osteum positive and negative groups. If I summarize the findings, in adult group there were 122 accessory maxillary osteum. In positive group, sinusitis, mucosal thickening, primary maxillary osteum obstruction was found statistically significantly higher than the negative group. Under 10 years old, we saw only 2 accessory maxillary osteum. There were sinusitis in 84 sinuses and 49 children. In the group under 10 years of age, statistically significantly less accessory osteum presence was detected. Until today, according to previous studies, there are some hypotheses. Some authors suggesting that this is a perforation due to sinusitis. Some says it's a variation causing sinusitis. Maybe it's disturbing the mucous circulation and causing two-hole syndrome. It can be one of the reasons of failure in functional endoscopic sinus surgery. Some authors suggesting to repair defects. It may be a compensation as a second drainage pathway. According to our results, we are thinking it's an acquired defect, maybe a perforation due to sinusitis or a compensation mechanism. There are concomitant sinus pathologies such as sinusitis, mucosal thickening, and primary maxillary ostium obstruction. It's important to tell about this ostium in radiological reporting because the size of defects can be repaired and we may prevent the failure in functional endoscopic sinus surgery. And thank you for listening.
Great. Thank you. And I guess hopefully we're back live. So again, that was a very interesting presentation, and it's something that we see all the time on our sinus images. And so it's interesting that you actually investigated this. I guess my one question would be, did you actually have a group of patients in which you saw the accessory ostium, but the patients had no sinusitis, i.e. true incidentals? And, you know, what is your interpretation of that? Because in my experience, I see them mostly as true incidentals where there's zero sinus disease, and even if there's sinus disease, it's very mild. So I just wanted to get your take on that.
Yes, thank you so much. Yes, we didn't see sinusitis or sinus pathologies all the patients. Most of patients don't have sinusitis, but have accessory ostiums. But maybe it's a defect for sinusitis and repairing it, maybe healing it, we don't know yet. But we are sure that it's an acquired defect, so we don't know in children. But which mechanism opens it, we don't know yet.
Okay, great. Thank you.
Thanks.
Hello, my name is Paul Bunch, and it is my pleasure to be co-moderating this session with Dr. Muniz, Dr. Forghani, and Dr. Kelly. Our next presentation is number 203, entitled Predictors of Imaging-Based Diagnosis of Causes of Throat Pain in the Emergency Room Setting. Our presenter is medical student Khoi Nguyen.
My name is Khoi Nguyen, and I am a medical student from Weill Cornell Medical College presenting on the predictors of imaging-based diagnosis of causes of throat pain in the ER setting. I do not have a financial interest in commercial products or services related to the subject of this presentation. To provide some background and context, throat pain is an extremely common chief complaint in both the ambulatory and ED setting, accounting for approximately 2% of all ED visits in the US in 2017. Though the usage of CT in the pediatric population has been decreasing after 2010, possibly due to new pediatric clinical decision rules, between 1995 and 2007, the usage of CT in the ED in the US has been increasing exponentially from 2.8% to 13.9% of all patient visits. This dramatic increase has implications regarding increased healthcare costs as well as increased exposure to ionizing radiation. Given the prevalence of patients presenting with throat pain coupled with the data regarding CT usage trends in the ED, the purpose of this study was to determine the diagnostic yield of CT performed in the ED setting for the evaluation of throat pain and to identify factors predictive of an imaging-based diagnosis. To clarify, we define an imaging-based diagnosis as a diagnosis rendered on the radiology report that is consistent with the patient's presentation and would explain the patient's throat pain. This was an IRB-approved, HIPAA-compliant retrospective cohort study examining patients presenting to the ED at a large urban hospital with the chief complaint of throat pain. Using a database search based on ICD-9 and 10 and CPT codes, we generated an initial list of patients that underwent contrast-enhanced CT or non-contrast CT of the neck for the evaluation of their throat pain between August 2013 and September 2019. In total, there were 646 CECT/NCCT exams that met this criteria. With regards to exclusion criteria, we excluded exams for patients who presented to the inpatient and outpatient settings, as well as the repeat imaging exams of those who received serial examinations. In total, 367 exams were included in this study. If a cause of throat pain was identifiable based on imaging, an exam received the designation of having an imaging-based diagnosis. If no cause of throat pain was identifiable, an exam received the designation of having a non-imaging based diagnosis. The imaging-based diagnosis exams were further subclassified according to disease etiology, which included infectious, inflammatory, malignant, foreign body, trauma, and other. For example, some infectious etiologies of throat pain identified on imaging were tonsillitis and peritonsillar abscess. Some malignant etiologies of throat pain were squamous cell carcinoma. For each exam, we also collected demographic information such as gender and age, as well as clinical variables from their initial presentation, including physical exam findings like cervical lymphadenopathy and laboratory data such as white blood cell count. In order to determine which variables were significantly associated with having an imaging-based diagnosis, continuous variables were tested using Wilcoxon rank sum test, and categorical variables were tested using chi-squared. Least absolute shrinkage and selection operator, or LASSO, was used as a multivariable regression model to assess for the association between selected variables and the odds of having an imaging-based diagnosis. In our cohort, 67.57% of exams had an imaging-based diagnosis, while 32.43% did not. There was a significant difference in the average age between the two groups, with the imaging-based diagnosis group having a younger age. Within the imaging-based diagnosis group, the majority of throat pain etiologies were identified as infectious or inflammatory on imaging. Here we have some examples of exams that would be categorized as having an imaging-based diagnosis. Peritonsillar abscess and tonsillitis would be subclassified as having an infectious etiology. The results of our bivariate analysis revealed that several physical exam findings such as cervical lymphadenopathy, tonsillar swelling, and oropharyngeal edema were significantly associated with having an imaging-based diagnosis. Moreover, laboratory variables such as higher temperature and white blood cell count were also significantly associated with having an imaging-based diagnosis. The results of our multivariate analysis revealed that for continuous variables, a higher white blood cell count is associated with a greater odds of having an imaging-based diagnosis. For discrete variables, tonsillar erythema on physical exam is associated with a greater odds of having an imaging-based diagnosis. To summarize some key points, more than half of patients who underwent CT evaluation for throat pain in the ED received an imaging-based diagnosis. Of those that did, infectious and inflammatory etiologies were among the largest diagnostic subcategories. Patients were significantly younger in the imaging-based diagnosis group. Several variables such as an elevated temperature, leukocytosis, and physical exam findings of oropharyngeal edema and erythema were significantly associated with having an imaging-based diagnosis. Given these findings, patients who present to the ED with throat pain who would most benefit from a CT scan of the neck for an imaging-based diagnosis are those who present with signs and symptoms of an infection. Given that the group with an imaging-based diagnosis were younger and had more infectious etiology, it makes sense that the physical exam and lab findings that are indicative of an infectious process like tonsillitis or peritonsillar abscess would yield an imaging-based diagnosis. Future directions regarding this project would be to expand the cohort of patients to capture patients evaluated for throat pain in the inpatient and outpatient settings, as the etiologies of these patients may be much different than those that present acutely to the ED. Moreover, a prospective study comparing the long-term outcomes between the two groups of patients would be interesting. For example, at 6 months after discharge, did patients in the non-imaging-based diagnosis group end up with the final diagnosis? Were similar patients between the two groups managed differently? Thank you.
Thank you for the nice presentation. I had a question. This is Dr. Fergani. So, one of the challenges when it comes to utilization is that diagnosis is partly statistical. So I want you to comment on two things. One is that many patients who present with throat pain don't get imaged, and that distinction is important. So usually when they get imaged, there was a reason, there was a concern. And the second part is when you're trying to stratify, diagnosis is a statistical thing. And one of the uncomfortable things, if you're going to limit imaging or utilization, is also how many are you willing to miss if you're going to restrict imaging? Because that's really the balance, right? How many negatives is acceptable per positive? Can you comment on those?
Sorry, could you repeat what your questions were?
Yeah, so the first question is, there are two challenges here, because many patients with throat pain are not going to get imaged when they present to the emergency department. So usually there's a concern already, at least in most practices I'm aware of. That's why they get upgraded to having image, because there's a concern for complication. So that in a way makes that there's already been some selection. And the second point is a more general thing. When you're trying to look at utilization is a statistical, right? So if you're going to, let's say these indications should not be imaged, the real question you're answering is how many are you willing to miss in terms of, so how many negatives are acceptable, the ratio of negative to positive. So what are your thoughts on that?
We have a med student, so maybe we should.
Koi. Maybe Koi's volume isn't working. So I can sort of help to comment. So in terms of the first question, that's totally true. And I think that Koi's project is really just focusing on those patients who have had imaging, not the total population of patients with throat pain in general. So, your point is totally well taken, that, it really doesn't teach us a lot about all patients with throat pain. It's really just those with throat pain and CT imaging. So, in future, a future thing to look at would be what portion of those patients coming into the ED with throat pain actually have imaging done. And that speaks to the point that, something like tonsillitis, for instance, doesn't really need CT imaging for diagnosis. And then in terms of the second question, in terms of guiding image utilization, that is true. I think, we would have to, look at this a bit more prospectively in terms of, outcomes in patients with and without imaging. And then, again, looking at some of the associated findings, the fact that many of these patients do have tonsillitis or other things that don't necessarily need imaging for diagnosis. I think delving into those patients' charts and having a better understanding of, what else occurred during their episode, would definitely be informative. If Koi can hear me, he can chime in and say if he agrees.
Thank you very much, by the way. Very nice presentation.
That was a wonderful presentation, and I think it's so awesome to see medical students presenting at this conference. That makes me feel great about the future. So thank you so much.
Thank you.
The next presentation is by Dr. Kushal Naha. The title of the presentation is Preoperative Determination of Depth of Invasion in Oral Cavity Squamous Cell Carcinoma by Standard Cross-Sectional Imaging with CT and PET-CT.
Good morning, everybody. My name is Kushal Naha, and on behalf of all my co-authors, I'm happy to present this paper titled Preoperative Determination of Depth of Invasion in Oral Cavity Squamous Cell Carcinoma by Standard Cross-Sectional Imaging with CT and PET-CT. This is our disclosure statement. We know that depth of invasion is an indicator of metastatic potential in oral cavity squamous cell carcinoma. The purpose of this study was to investigate the accuracy of preoperative determination of depth of invasion in oral cavity squamous cell carcinoma by standard cross-sectional imaging with CT and PET-CT. This was a retrospective IRB-approved record-based study involving consecutive patients with histologically proven oral cavity squamous cell carcinoma who presented to the ENT department at the University of Missouri and underwent preoperative imaging with contrast-enhanced CT and PET-CT with in-plane resolutions of 3 mm per slice and 5 mm per slice, respectively. For the purpose of this study, the images were independently reviewed by 2 radiologists who were blinded to the results of pathological assessment. Pathological assessment of depth was separately determined from pathology reports. Radiographic depth was then correlated to pathological depth by means of statistical analysis using IBM SPSS software. 79 patients were screened for this study, of whom appropriate radiographic studies were available for 63 patients. 55 of these patients had undergone CT imaging, while PET was available in 33 patients. This is a summary of baseline characteristics. Mean age was 61.5 years. More than 70% of these patients were male. Patients were overwhelmingly Caucasian in ethnicity, and nearly 85% were either current or former smokers. Looking at the breakup by T-staging, we can see a broad distribution with patients across all categories, with the most patients being in the T2 category. Mean pathological depth of invasion was 12.3 millimeters, and once again patients were distributed across a wide range of depths. CT determined depth and PET-CT determined depth both correlated well with pathological depth of invasion. Sensitivity and specificity for detection of deep invasion, defined as a depth greater than 10 millimeters, is noted below for both CT and PET, and you can see that CT performed better. On subgroup analysis, both CT and PET did not perform well in patients with superficial tumors defined as a depth of less than 5 millimeters. On the other hand, both CT and PET correlated well with pathological depth in patients with deep tumors. Both CT and PET overestimated depth of invasion, but this tendency was more pronounced with PET. The following two graphs demonstrate this finding for CT and PET-CT respectively. Depth of invasion has been shown to robustly predict nodal mets and therefore patient outcomes in oral cavity squamous cell carcinoma. Superficial tumors are known to be associated with a low incidence of nodal mets, while deep tumors are known to be strongly associated with both nodal mets and local recurrence. Accurate determination of depth of invasion is crucial to surgical planning and determining the need for neck dissection in patients with clinically node-negative disease. Prior studies have shown that MRI can accurately determine depth of invasion in oral cavity squamous cell carcinoma. While traditional MRI performs well with tumors deeper than 5 millimeters, newer high-resolution MRI performs well regardless of depth of invasion. On the other hand, PET-CT has been shown to accurately predict nodal involvement, tumor volume, and the presence of bony invasion. There is, however, no available data on assessment of depth of invasion by PET-CT and only limited data on CT assessment. A retrospective study involving 21 patients over a period of 9 years showed similar effectiveness for CT and MRI in determining depth of invasion. It is also important to note that these studies were conducted in Taiwanese, Korean, Italian, and Japanese populations respectively. Some of the lacunae in current knowledge that were addressed in this study include showing that CT and PET-CT are viable alternatives in patients unwilling or unable to undergo preoperative MRI. Since PET-CT is already widely used for detection of nodal involvement, this would also obviate the need for performing additional MRI in these patients. Finally, this study addresses the lack of US-based data in this subject. Some of the limitations of this study include its retrospective design, small study size, and limited applicability to non-white US adults, given that the study population was overwhelmingly white. In conclusion, preoperative determination of depth of invasion by CT and PET correlated well with pathological assessment in patients with oral cavity squamous cell carcinoma. On subset analysis, correlation was significant in tumors with pathological depth over 10 millimeters. These are our references. Thank you for your time.
Thank you for the talk on the important topic. I had some questions and maybe some clarifications you can make while answering those questions. First is when you measure, I assume you use more than one planes. But my specific questions are twofold. One is that I noticed that there are 3 millimeter and 5 millimeter slices. Now, as you can imagine, using thick slices itself can introduce a good degree of error. I know that I read my head and neck cancer cases at 1.25 millimeter routinely, so I would like to comment you to comment on that in terms of impact. And then with the PET CT, were these PET CTs where the CT was contrast enhanced? I assume, right?
No, actually, well, first of all, thank you for having me here. So to answer the first question, yes, I agree that the slices were a little thick, and that was actually a problem, as we saw with the superficial tumors, because they were just too thin to get an accurate measurement. And part of the reason that we ended up in that situation was because this was, as I said, a retrospective study, and a lot of the ENT, the providers here actually prefer to get these CTs or PET CTs more for to assess the nodal involvement, CTs of the neck and CTs of the chest. And this was kind of used, it was done retrospectively, where the radiologists involved in the study went back and specifically looked at those sections, trying to identify what the depth of invasion was. So the depth of invasion wasn't really looked at when it was first done, the study. They were never officially reported as part of the study, as part of these imaging reports. This was done completely retrospectively afterwards, when they went back and looked at it. So the images were not ordered or, with any kind of intention of looking at the depth of invasion. This was, and really what we wanted to show here was that even without really thin slices, the radiologist was able to, predict the depth of invasion to a reasonable degree. And we would expect that if you actually used a lot of thinner slices with the intention prospectively of looking at depth of invasion, you would probably get a lot better correlation, and probably better correlation with with thinner tumors. So this was almost like an exploratory study where we wanted to see if it could even be done using CTs and even PET CT, because there's very limited data on that. Secondly, with regard to the PET CTs, those were actually just regular PET CTs. They were not contrasted. Again, what they were doing was they were really looking for lymph nodes in the neck and elsewhere. And so we just retrospectively used the same PET CT to read it. But that's why, if you look at the sensitivity and the specificity of the PETs, they weren't really great. And I think part of the reason was because they weren't contrast enhanced, unfortunately.
Thank you so much. I really enjoyed the presentation. I think you did a great job answering the questions. Just a comment to the moderators. We have about 45 minutes left in the session. I believe we have 6 presentations left, running at 7 minutes each. So I would propose to the group, so that we can keep this on time, which is one of our jobs, that maybe we just start playing the recorded introductions and the recorded things, and we can move these great questions and comments to the chat box where a lot of interaction's happening. And I'm so excited to see so many participants.
Thank you.
The next presentation is by Dr. Danielle Copeland. The title of the presentation is Cavernous Sinus Thrombosis, a 20-year retrospective review of a South Australian metropolitan population.
Hello, my name is Danielle Copeland and I'm a radiology registrar in Adelaide, South Australia. And today I'm going to speak on cavernous sinus thrombosis, looking at a retrospective review of 2 Australian metropolitan populations. None of the authors have any financial disclosures or conflicts of interest. First, just a brief introduction to the topic. So cavernous sinus thrombosis is a rare but potentially fatal entity. It has a very low reported incidence rate of anywhere from 0.2 to 1.6 per 100,000. And as it is so rare, it is actually quite difficult to accurately measure the incidence. There are many causal factors. The most common is infection, usually paranasal sinusitis, orbital cellulitis, but also any dental abscess or facial infection, trauma or any tumor infiltrate, any prothrombotic state, including the peripartum period, and sometimes it is idiopathic as well. Clinical findings are relatively non-specific, including fever, headache, ophthalmoplegia, and sometimes some periorbital swelling. And as such, imaging plays a very vital role in the initial diagnosis, but also in identification of potential causes, and as well as identifying potential complications. It's in the potential complications that we really see what a serious condition cavernous sinus thrombosis can be. Its complications include meningitis, dural empyema, cerebral abscess, cerebral infarct, or further dural venous sinus thrombosis. Key imaging findings are mainly CT and MRI based. So on CT, looking at a non-contrast enhanced study, looking for that hyperdense thrombus sign within the cavernous sinus itself. On contrast enhanced imaging, you can really see distension of the cavernous sinus, and quite often you can see a filling defect within. Sometimes you can see a distended superior ophthalmic vein as well. On MR, you have some very direct signs, including change of signal intensity within the cavernous sinus itself, particularly looking at the size and contour of the cavernous sinus, with the lateral wall being one of the most specific areas to look at. Indirect signs, again looking for a dilation or thrombus of that superior ophthalmic vein, exophthalmos, adjacent dural enhancement, and any features of sinusitis or facial infection. So the aim of this study was to describe the imaging findings of cavernous sinus thrombosis in 2 Australian tertiary referral centres. So this is a multi-centred study with data collected from 2 metropolitan populations. The first was Flinders Medical Centre, a tertiary hospital in Adelaide, South Australia, and the second, the Royal North Shore Hospital, a tertiary hospital in northern Sydney, New South Wales. So keyword searches were performed through the RIS records, looking for cavernous sinus thrombosis, and cases were then reviewed. Cases of carotid cavernous fistula were excluded from this study. So overall, 5 cases were found in the Flinders Medical Centre data and 7 cases were found in the Royal North Shore data. The most common causes were infective, particularly sinusitis and orbital cellulitis. We did find 1 case related to pregnancy, so in that peripartum period, and another case related to trauma. The complications that we saw in these cases were meningitis, dural empyema, further dural venous sinus thrombosis, as well as skull-base osteomyelitis. So looking now at some of those key imaging findings. So first looking at a contrast-enhanced CT in an 80-year-old who presented with headache. Here on that right side, you can appreciate a subtle filling defect and slight enlargement of the right cavernous sinus, as well as the background features of sinusitis as well, so also pointing towards a causal factor. The next case here is in a patient who was 39 weeks pregnant. Here, again, a contrast-enhanced CT, and you can see the filling defect in that left cavernous sinus. Also illustrated nicely here, you can see that distension of that superior ophthalmic vein, and also you'll notice that the 2 globes are at different levels, indicating associated exophthalmos. One of the other nice findings in this study is that there actually wasn't any features of sinusitis present, so you can see that sphenoid sinus is very pristine in this image. The next case is a 55-year-old who presented with sinusitis. So here we actually have bilateral cavernous sinus thrombosis, and you can see that sort of patchy filling defect there, as well as a pacification and enhancement of the sinuses in keeping with underlying sinus disease. Additionally, again, we see that distension of that superior ophthalmic vein, slightly more prominent on the right in this case. Here's another case of a patient that presented with sinusitis. So here you can see the pacification of the paranasal sinuses, as well as that patchy filling defect, and nicely illustrated on the restricted diffusion imaging. You can see the restricted diffusion through that cavernous sinus, suggestive of infective material spreading through. Next, we'll look at a case who presented with headache and nasal stuffiness. So first you can see here that there's ethmoid and sphenoid sinus opacification in keeping with sinusitis. Again, we have bilateral cavernous sinus filling defects. And additionally here, I hope you can appreciate that there's some right orbital inflammatory tissue as well as right proptosis. We have that pre- and post-septal phlegmonous reaction, as well as some right leptomeningeal and pachymeningeal enhancement within that anterior cranial fossa. We also see that there's an extra-axial empyema within the posterior fossa. Here we can see that the filling defect within the right cavernous sinus is contiguous with that superficial petrosal sinus and seen extending into the transverse sinus as well. So again, that complication of further dural venous sinus thrombosis. Here again, highlighting that extension. Here nicely illustrated, we see restricted diffusion through those sinuses, extending through that right anterior cavernous sinus and along the right tentorium, implying a subdural empyema and then a further complication of ventriculitis. Within the same case as well, we can also see that there's that abnormal signal within the clivus indicating a skull-base osteomyelitis. And on the MRV, we see lack of filling of that right transverse sinus, which does confirm extension along and further dural venous sinus thrombosis. Obviously, all studies do have limitations, and this is a retrospective study, and as such, any undiagnosed cases that might have been found at autopsy or cases that were just treated clinically were not included in this study. A metropolitan population doesn't reflect the population in total, and there may be a difference in the rural population as well. So overall, in summary, we've described the imaging findings of cavernous sinus thrombosis in 2 tertiary referral centres within Australia. And interestingly, this is the first case series from Australia that has been reported. Thank you very much for your attention.
Thank you for that great presentation. And I think the plan that we kind of discussed via the chat was to continue rolling with the recorded presentations until we're closer to on time, if that's okay.
Good afternoon. I'm Hillary Kelly, and I'm honored to present the next 2 oral presentations. First up, we have oral paper number 206, presented by Ayman Nada, on accuracy of 4D multiphasic computed tomography and preoperative localization of parathyroid adenoma in patients presented with primary hyperparathyroidism.
Hello, everybody. This is Ayman Nada from the University of Missouri. I'd love to thank the ASHNR organizing committee for giving me this opportunity to present this work at the ASHNR meeting. It's my pleasure to present this work that have been done at the University of Missouri on the accuracy of 4D multiphasic computed tomography in preoperative localization of parathyroid adenoma in patients presented with primary hyperparathyroidism. We don't have any relevant disclosure. We aim to evaluate the accuracy of 4D multiphasic CT in accurate preoperative localization of parathyroid adenoma hyperplasia in patients presented with primary hyperparathyroidism. This is an IRB approved retrospective study. We included patients underwent 4D CT and surgical intervention with available histopathological results. 80 patients presented to our department for evaluation of primary hyperparathyroidism during January 29 till June 2020. Of them, 73 patients had 4D multiphasic CT of the neck. Of them, 37 patients underwent parathyroidectomy with available histopathological evaluation. We found 43 lesions within these patients on 4D CT. Imaging technique of 4D multiphasic CT included non-contrast phase, cover the thyroid gland, arterial phase from the mandible to the carina, and venous delayed phase. We reformatted the images into axial, coronal, and sagittal, and then saved on the PACS. Image evaluation included subjective evaluation of the density on the non-contrast phase, compare that to the thyroid gland, evaluation of the enhancement pattern on the arterial and venous phase, and measurement of the average Hounsfield unit in each phase, and the presence or absence of polar vessel sign was evaluated. Here is the method for measurement of the density and Hounsfield unit using the point analysis tool, because these lesions are very, very small. And here is an example for the polar vessel sign. Our study included 37 patients, 10 males and 27 females. The mean age was 64 years and the age ranged from 34 to 89 years. We found 43 hypervascular lesions, 22 in the right side and 21 within the left side. The mean size of the nodule was 14 millimeter. Depicted nodules had a mean Hounsfield unit of 46, 164 and 98 Hounsfield unit in non-contrast, arterial and venous phases respectively. The polar vessel sign was positive in 70% of patients. We found that the overall sensitivity of 4D multiphasic CT in detection of parathyroid abnormality was 95%. Here we can see the relation between each group according to the Hounsfield unit, and when they divided according to the gender. Here is the female group and this is the male group. Here we correlated the quantitative measurement of the Hounsfield unit into age, and we see overlap in between the three groups. Here are the log curves. The Hounsfield unit in venous phase was found to be positively correlated to the lesion size, Hounsfield unit in non-contrast and arterial phase. However, overall, no significant correlation was found between the Hounsfield unit and the pathological diagnosis. Here's an example of a parathyroid adenoma in a 54-year-old female presented with primary hyperparathyroidism. We can see hypervascular nodule just below the left thyroid lobe, and this is another example of parathyroid adenoma in a 74-year-old female with hypervascular nodule at the anterior mediastinum. This is an interesting example of a parathyroid adenoma within the left thyroid lobe in a 69-year-old female presented with primary hyperparathyroidism. We can see a mildly hypodense nodule within the left thyroid lobe with arterial enhancement and subtle washout in the venous delayed phase. Again, this is an example for the quantitative measurement of the Hounsfield unit for the nodule. This is a parathyroid adenoma in a 75-year-old female presented with primary hyperparathyroidism, and please note the relative hypodense nodule within the right thyroid lobe and the slight arterial enhancement and washout in the venous phase. And here is the measurement. It measures 38 Hounsfield unit in the non-contrast phase with significant increase in the Hounsfield unit in the arterial phase 172 and rapid washout and decrease the Hounsfield unit into 98 in the venous phase. So the measurement could help in the equivocal nodules. In conclusion, 4D multiphasic CT of the neck was found to be useful in preoperative evaluation and localization of hyperthyroid adenoma hyperplasia in patients presented with primary hyperparathyroidism. The typical imaging findings of hyperthyroid adenoma hyperplasia include arterially enhancing hypervascular nodule with rapid washout in the venous delayed phase. The polar vessel sign is not specific. However, it could be helpful in direct sign for a parathyroid hyperplasia or parathyroid adenoma. The quantitative measurement of density or Hounsfield unit in different study phases have overlap between the lesions, but it could be helpful in patients with equivocal nodules. These are the references. and thank you for your attention.
Our next speaker is Jason Yoon, presenting oral paper number 207, Preoperative Assessment of Tumor Thickness for Oral Tongue Squamous Cell Carcinoma using Computed Tomography.
Hi everyone, my name is Jason Yoon and I'm one of the neuroradiologists at Massachusetts General Hospital. Today I'll be presenting our project on preoperative assessment of tumor thickness for oral tongue squamous cell carcinomas using CT. This project has been spearheaded by Dr. Amy Giuliano from Massachusetts Eye&Ear. Accurate assessment of tumor thickness is critical for evaluation and management of oral tongue squamous cell carcinomas. Currently, the preoperative assessment tools include CT, MRI, and/or manual palpation. The aim of our study is to evaluate reliability and accuracy of preoperative CT in assessing tongue tumor thickness. To do this, we compared tumor thickness measurements by two different neuroradiologists. We also compared tumor thickness measurements from CT to those from intraoperative ultrasound and histopathologic assessment. In this study, we prospectively identified 26 patients, adult patients with oral tongue squamous cell carcinomas. These patients underwent tumor resection by a single surgeon between the March of 2016 and April of 2019. During the surgery, intraoperative ultrasound was used as imaging guidance. For intraoperative ultrasound, a hockey stick probe was used from Philips. Longitudinal and transverse planes relative to the long axis of the tumor was imaged. Both still images and cine clips were obtained. In terms of preoperative CT, 15 patients had conventional CT neck with intravenous contrast. 4 patients had preoperative PET CT with intravenous contrast. For image interpretation, we had 2 different readers with variable degree of neuroimaging experience. For any major discrepancies, we had an arbitrator with 16 years of head and neck imaging experience who resolved the discrepancies. For tumor thickness measurements, we measured the maximum distance between the superficial surface of the tumor to its deepest margin. As you may know, the depth of invasion as measured from the mucosa to the deepest margin of the tumor is also a very important factor in management of oral tongue squamous cell carcinoma. However, on CT, it was difficult to differentiate between the mucosal surface and the superficial surface of the tumor. So for the purpose of this study, we only focused on the tumor thickness measurements. For each measurement and interpretation by each reader, we also assessed the confidence level using the Likert scale. In the scale that we used, the score of 0 was not confident, and the score of 4 was very confident interpretation. Here is an example of a well-visualized oral tongue squamous cell carcinoma on CT. Here on the axial neck CT with contrast at the level of the oral tongue, we have a well-delineated enhancing lesion along the right lateral aspect of the tongue corresponding to the known squamous cell carcinoma. This is also seen on the coronal view with the asymmetric enhancement along the right aspect of the tongue. In comparison, here is a poorly visualized oral tongue squamous cell carcinoma secondary to extensive streak artifact from the dental hardware. In our cohort, we had 19 of 26 patients with preoperative CT. The mean age was 59.6 years old with a range of 27 to 82 years old. There were 13 male patients and 6 female patients. When we examined the CT tumor thickness measurements by each reader, we noticed that only a subset of patients had visible tumors on CT. Reader number 1 identified visible tumors in 52% of the cases, and reader number 2 identified tumors in 63% of the cases. The mean tumor thickness measurements by reader number 1 was 6.8 millimeters, and for reader number 2 it was 5.2 millimeters. The mean Likert score was also low for both readers, and reader number 1 reported 0.42 of Likert score, and the reader number 2 had 0.74 of a Likert score. Just to remind you, the Likert score of 0 is not confident and 1 is less confident. Only 2 out of 19 cases, or 11% of the cases, had concordant measurements, i.e. identical tumor thickness as measured by both readers. When we compared the tumor thickness measurements by CT from both readers and compared it against intraoperative ultrasound and histopathology, we also noticed some discrepancies. For instance, on CT, the median tumor thickness was 5 millimeters. In comparison, we had 8 millimeters of median tumor thickness on intraoperative ultrasound and 9 millimeters on histopathology. A similar trend was observed when we looked into mode tumor thickness and as well as the mean tumor thickness, as well as the range. We also looked at the correlation between the tumor thickness measurements between different modalities. On the left side, we have a comparison between CT measurements and histopathologic measurements, and overall there was a poor correlation between the two modalities with a low Pearson coefficient of 0.10. In comparison, for intraoperative ultrasound and histopathologic measurement comparison, there was an excellent correlation with a high Pearson coefficient of 0.92. So in our cohort, we had fewer than 65% of tongue tumors in our cohort with visible tumor on CT. The Likert score for even the visible tumor was pretty low, ranging between 0 and 1. The correlation between the tumor thickness measurements on CT and histopathologic measurements was low, and the correlation between the tongue tumor thickness as measured on ultrasound and histopathology was high in comparison. So in summary, in our cohort, we saw that the preoperative CT is neither accurate nor reliable for assessment of oral tongue squamous cell carcinoma tumor thickness, and the absence of visible tumor on CT does not necessarily exclude the presence of the tumor. As comparison, ultrasound was more accurate and reliable in detection of the tongue tumor, as well as assessment of tumor thickness. Thank you for your
Our next presentation is number 208, entitled Incidental Parathyroid Lesions on Trauma CT, Incidence and Assessment for Possible Primary Hyperparathyroidism. Our speaker is Dr. Mike Dietzen.
Hello, my name is Michael Dietzen, and I am a diagnostic radiology resident at Wake Forest. I'm really excited to be participating in the American Society of Head and Neck Radiology virtual meeting, and I hope to be able to attend this great conference in person someday. You should know that this is the first research project I've ever participated in, and this is my first time presenting at an academic conference. I'm grateful to Dr. Randall and Dr. Bunch for their mentorship. Neither I nor my co-authors have anything to disclose. Primary hyperparathyroidism refers to an intrinsic parathyroid glandular abnormality resulting in increased parathyroid hormone. Primary hyperparathyroidism is the most common cause of hypercalcemia. The risk increases with age, and it affects women more commonly than men. Primary hyperparathyroidism also conveys an increased risk of heart attack, stroke, and death, such that it is not a benign disease. The fact that primary hyperparathyroidism is underdiagnosed is well documented in the literature. In our clinical practice of interpreting emergency department CT, we have observed what appear to be enlarged parathyroid glands among trauma patients undergoing non-contrast cervical spine CT immediately followed by neck CTA, which is not all that different from the first two phases of the parathyroid 4D CT protocol. If the calcium is elevated, the decision is straightforward. We report the finding and recommend further evaluation. However, sometimes the calcium performed in our emergency department falls within the reference range, and at least for us, this scenario is less clear-cut. One option would be to say, well, the calcium is normal, I'm going to blow this parathyroid gland off, but is that necessarily the right thing to do? What about normal calcemic primary hyperparathyroidism? And what if the patient has received fluid resuscitation in their trauma care? How much can we rely on that serum calcium level? These observations and these questions led us to conduct a study, the purposes of which are to, one, determine the prevalence of visible parathyroid glands among emergency department patients undergoing trauma CT and falling within the typical age range for primary hyperparathyroidism, and two, assess for clinical and laboratory evidence for primary hyperparathyroidism among those patients with visible parathyroid glands. For this retrospective IRB-approved HIPAA-compliant study, a local radiology report database was queried to identify 400 consecutive neck CTA examinations performed among patients aged 47 to 74 years in our institution's emergency department between April 2018 and March 2020. This particular age range selection was informed by data from the Collaborative Endocrine Surgery Quality Improvement Program and intended to include the mean age of patients with primary hyperparathyroidism, plus and minus 1 standard deviation. Neck CTA examinations were excluded if no cervical spine CT was obtained during the same care episode, if the cervical spine CT did not cover the neck CTA area of interest, and if a neck CTA examination from a given patient had already been included in the study cohort so as to avoid counting any one patient twice. Following a parathyroid 4D CT training session, the images from all neck CTA and cervical spine CT pairs were reviewed by one radiology resident who assessed for the presence of visible parathyroid glands. A 4 millimeter minimum size cutoff was used. Possible glands were flagged for additional review by an attending neuroradiologist with 4 years experience interpreting parathyroid 4D CT. The attending neuroradiologist made the final gland visibility determination, and when visible, the attending neuroradiologist measured and recorded the maximum dimension of the largest visible gland. A fellowship-trained endocrine surgeon with 5 years experience managing hyperparathyroidism performed an in-depth electronic medical record review of all patients determined to have visible parathyroid glands. On the basis of documented laboratory and clinical data, the surgeon placed each patient into one of these 5 primary hyperparathyroidism likelihood categories: very likely, likely, indeterminate, unlikely, and very unlikely. Of the 400 neck CTAs reviewed, 63 are excluded for reasons listed. This yielded 337 neck CTA and cervical spine CT pairs. 96 pairs were flagged by the radiology resident as possibly containing a visible gland. Of these, the attending neuroradiologist determined at least one parathyroid gland to be visible in 18 patients. This Table 1 type figure summarizes the characteristics of the study cohort. Note that there were more than twice as many males as females in the overall cohort of trauma patients, but that parathyroid glands were more likely to be visible in females than males. This observed difference was statistically significant and would be in keeping with the substantially higher prevalence of primary hyperparathyroidism among women than men. For the 18 patients with visible parathyroid glands, this table summarizes the surgeon's likelihood classification and provides data on gland size. I'd like to highlight that the ED calcium levels for 83% of the patients with visible glands fell within the reference range, including 2 patients classified as likely of having primary hyperparathyroidism by the reviewing surgeon, as well as all 6 classified as indeterminate. The 5 patients classified as highly likely or likely of having primary hyperparathyroidism exhibited larger parathyroid glands than the 7 patients classified as unlikely or highly unlikely, and this observed difference in gland size between the 2 groups was statistically significant. However, it is worth noting that the patients classified as indeterminate exhibited glands as small as 4 millimeters. In summary, parathyroid glands measuring at least 4 millimeters were visible in 5% of our cohort with a mean gland size of 9 millimeters. The prevalence of visible glands was significantly higher among women than men. Although the likelihood of primary hyperparathyroidism appears to increase with increasing gland size, confident determination of the presence or absence of primary hyperparathyroidism solely from electronic medical record review is difficult even for a surgical specialist. This was particularly true in our cohort, given that PTH was only available in a single patient. Based on the data we have presented to you, we conclude that it is likely most appropriate for radiologists to report parathyroid glands incidentally visible on CT performed for trauma or other reasons, and to suggest formal biochemical screening for possible primary hyperparathyroidism. Thank you for your attention.
Our next presentation is number 209, entitled Initial Radiologist and Referring Provider Experience with Neck Imaging and Reporting Data System in an Academic Medical Center. Our speaker is Dr. Nuwan Migala.
Hello, my name is Nuwan Migala, and I'm an intern in the General Surgery Department at Wake Forest School of Medicine. Today I will be presenting on the Initial Radiologist and Referring Provider Experience with the Neck Imaging and Reporting Data System, better known as NIRADS, within an academic medical center. These are our disclosures. We have known for some time that there is variability in the ways different radiologists describe and report the same imaging findings, and that there can be substantial differences between the radiologist's intended meaning in a radiology report and the perceived meaning to the referring physician. In response to these challenges, a number of standardized reporting systems have been developed and have received an endorsement from the American College of Radiology. Generally speaking, these reporting systems aim to simplify communication, clearly direct clinical management, facilitate RAD path correlation and quality improvement, foster evidence-based practice, and advance patient-centered care. One of these systems is NIRADS. NIRADS was developed as a reporting system for surveillance imaging of patients with treated head and neck cancer. It employs standardized terminology, numeric levels of suspicion, and linked management recommendations. NIRAD's categories of suspicion range from no evidence of recurrence to definitive recurrence. The radiologist assigns one of these categories to the primary site and also a category for the neck, typically meaning the cervical lymph nodes. Based on the assigned category, there is a linked management recommendation. For example, routine imaging follow-up would be recommended if there is no evidence of recurrence, whereas biopsy would be recommended if there is high suspicion of recurrence based on the imaging findings. So the neuroradiology group at Wake Forest School of Medicine, as well as the Head and Neck Tumor Board, all liked the sound of this and said to each other, hey, let's give this a try. So that brings us to the purpose of this study, which was to characterize our initial experience with NIRADS, both from the standpoint of the neuroradiologist, as well as from the standpoint of the otolaryngology, radiation oncology, and medical oncology referring providers. One method through which we attempted to capture our initial experience was surveying the neuroradiologist and the referring providers, including attendings, trainees, and advanced practice providers. These surveys were administered before and 3 months after the optional but encouraged adoption of NIRADS by the Wake Forest neuroradiologist. A 5-point scale was used ranging from strongly agree to strongly disagree. The neuroradiologist pre- and post-surveys consisted of 15 and 17 questions respectively and were intended to assess attitudes and opinions on reporting head and neck cancer surveillance neck CT studies, as well as on the perceived and actual effort of adopting NIRADS for neck CT reporting. The referring provider pre- and post-surveys consisted of 22 and 23 questions respectively and were intended to assess perceptions and preferences related to head and neck cancer surveillance neck CT reports. In addition to administering these pre- and post-surveys, we also wanted to get a sense of how frequently NIRADS was actually being used for neck CT reporting after optional adoption by the neuroradiologists. To do this, we performed an IRB-approved HIPAA-compliant search of a local radiology report database to identify patients with previously treated head and neck malignancy who underwent surveillance neck CT within 3 months following NIRADS adoption. And we asked a simple question: was NIRADS used? These are the survey response rates for the neuroradiologists and referring providers. As you can see, there were greater than 90% response rates from the neuroradiology attending and fellows. The overall response rates from the referring providers were lower, but we were glad to receive input from over 80% of the attendings. In the interest of time, I won't take you through all of the survey questions and responses, but I would like to highlight some of the survey results, beginning with the neuroradiologists. To orient you, the column height, light beige for baseline freeform reporting and gray for NIRADS reporting, corresponds to the mean survey response for each question item, with 5 corresponding to strongly agree and 1 corresponding to strongly disagree. The error bars indicate the standard deviation. A student t-test was performed to arrive at the reported p-values. As you can see, the neuroradiologists were less likely to agree that freeform reporting is the most appropriate for head and neck cancer surveillance neck CT scans after NIRADS implementation compared to before, and more likely to agree that standardized reporting is most appropriate after NIRADS implementation. The survey results also suggest that the radiologists consider NIRADS neck CT reports to be more helpful in guiding clinical management than the baseline freeform reports, and that NIRADS improved neck CT reporting consistency among the group of neuroradiologists. One potential barrier to NIRADS adoption is the perceived effort that it would require. Importantly, 88% of radiologists disagreed or even strongly disagreed that adopting NIRADS required substantial effort. Additionally, 88% of radiologists agreed or strongly agreed that the effort required was well worthwhile. Most neuroradiologists also agreed or strongly agreed that NIRADS facilitates clear, understandable reporting, that NIRADS improves radiologist consistency, and that they prefer using NIRADS relative to the baseline freeform neck CT reporting style. Here is a comparable graphical representation of referring provider responses to some of the survey questions. Compared to baseline freeform neck CT reports, the referring provider survey results indicate NIRADS reports to be more clear and understandable, and also to be more direct and less likely to hedge. Referring provider survey results also indicate a perception that NIRADS improved neck CT consistency from baseline and that general report satisfaction was higher following NIRADS adoption. Most referring providers agreed or strongly agreed with NIRADS reports being direct and not hedging, the NIRADS numerical suspicion rating being useful, the NIRADS management recommendations being useful. Generally, following the NIRADS management recommendation and wanting our radiologists to continue using NIRADS. Now let's turn our attention to the question of whether NIRADS was actually used. In the 3 months following NIRADS adoption, 192 head and neck cancer surveillance neck CTs were performed, of which NIRADS was used to report 60% of. The usage rates of NIRADS was highest among mucosal squamous cell carcinoma primary malignancies and lowest among non-squamous cell carcinoma head and neck primary malignancies. When stratified by month following optional NIRADS adoption, usage rates were lowest in month 1 and steadily increased over time. This is to say, the radiologists were choosing to use NIRADS with greater frequency over time. From these presented data today, we conclude that the adoption of NIRADS was not perceived to require substantial neuroradiologist effort and that most radiologists indicated the effort to be well worthwhile. Rates of NIRADS utilization steadily increased within the first 3 months of implementation, suggesting an increased preference for NIRADS among the group with greater experience using it. Additionally, referring providers indicated NIRADS neck CT reports to be more direct and more clinically useful than baseline freeform neck CT reports. Finally, we believe that these data support an overall positive initial experience with NIRADS among radiologists and referring providers at our institution. And for these reasons, we expect to continue to use NIRADS in our routine clinical practice. Thank you very much for your kind attention.
Our final presentation is number 210, entitled Diagnostic Performance of CT for the Detection of Extranodal Extension in Patients with HPV-Associated Squamous Cell Carcinoma of the Oropharynx. Our speaker is Dr. An Tran.
Hello, everyone. Thank you for joining us today for our talk titled Diagnostic Performance of CT for the Detection of Extranodal Extension in HPV-Associated Squamous Cell Carcinoma of the Oropharynx. This presentation will be given by me, An Tran, currently a radiology resident at Brigham and Women's Hospital, and of course would not have been possible without the help of the rest of my team, Doctors Glenn Hanna, Jonathan Scheinfeld, Benjamin Kahn, and Jeffrey Gwinnett. We have no disclosures. For this talk, we will go over the background and purpose of studying extranodal extension in HPV-associated head and neck cancer, review the approach and methods of our study, and finally discuss the findings and conclusion. The presence of extranodal extension in primary head and neck squamous cell carcinoma has been associated with worse prognosis, including increased rates of local regional recurrence, distant metastasis, and poorer survival. Lymph nodes with extranodal extension are a concern in patients with HPV-associated oropharyngeal squamous cell carcinoma, as the presence and detection of E&E may impact treatment strategy. This is because patients with E&E identified following surgical resection are often treated with adjuvant chemoradiotherapy rather than adjuvant radiation alone. Before going into the radiologic features of E&E, it may be helpful to see what it looks like under histology. Extranodal extension is defined as invasion of tumor cells beyond the capsule of a metastatic lymph node. This H&E image shown here demonstrates extranodal extension of a pathologic lymph node. The external capsule of the node is depicted by the asterisk, and the tumor is seen extending up to 5 mm past the border of the capsule. Several studies have actually previously evaluated the diagnostic performance of CT in detecting E&E in head and neck squamous cell carcinoma. These studies have used different criteria for determining radiologic E&E and have only shown variable success at predicting E&E. 4 of the more recent studies were examined, and features from these studies that demonstrated statistical significance in terms of sensitivity, specificity, or inter-observer agreement were included in our current study. In the end, 7 features were chosen from those studies, including perinodal fat stranding, absent perinodal fat planes, lobular contours, irregular nodal margins, central necrosis, matted or conglomerate nodes, and size greater than 30 millimeters. Perinodal fat stranding is seen on CT as stranding of the fat directly surrounding the node, often with interruption of the capsule or infiltration of the adjacent fat, muscle, or other surrounding structures. Absent perinodal fat planes, as demonstrated here with a heterogeneous lymph node directly abutting the adjacent muscle without a visible fat plane between the two structures. The next 2 features look at the contours and margins of the lymph node. A lymph node with lobular contour demonstrates undulations within its contours rather than smoothly spherical or oval contours. A node with irregular margins has margins that are spiculated or irregular, as seen here. Central necrosis can be seen on CT as a central region of low attenuation or even cystic appearance. Matted or conglomerate nodes are defined as a group of at least 3 adjacent nodes which lack a definable fat plane between them. Size was the last feature we examined. measured in greatest axial dimension from outer margin to outer margin. We had 3 main goals for this study. The first was to examine these 7 previously published criteria in a single study. Secondly, we wanted to train the imaging readers on these criteria based on the definitions that were just described and on images from the prior studies. And lastly, to determine inter-reader agreement for these features. The initial cohort for the study included 324 patients who had the diagnosis of cancer in the tonsil, base of the tongue, or oropharynx, and were seen in our tertiary head and neck cancer center with a surgical hospital admission in the last 5-year period. After retrospective chart review of the clinical notes, surgical history, pathology reports, and imaging studies, the cohort was further narrowed to 75 patients who had pathology-proven HPV-positive squamous cell carcinoma of the oropharynx, who underwent transoral robotic dissection or neck surgery and had available preoperative images. Next, we included 2 independent readers who reviewed the CT images and determined the presence of each of the 7 features. Statistical analysis was performed for each reader and included specificity, sensitivity, positive predictive value, negative predictive value, and accuracy. In addition, inter-observer agreement between the 2 readers was also obtained. For our results, in terms of positive and negative predictive values, all 7 features demonstrated low positive predictive values ranging from 0.26 to 0.46 and high negative predictive value ranging from 0.79 to 0.96. In terms of sensitivity and specificity, central necrosis had the highest sensitivity, ranging from 0.82 to 0.94, but showed low specificity. Size greater than 30 mm had the highest specificity, ranging from 0.82 to 0.84, but low sensitivity. The remaining features demonstrated both relatively low sensitivity and specificity. Next, accuracy for the 7 features was found to be variably low, ranging from 0.45 to 0.76. Finally, inter-observer agreement was found to be variable. It was highest for size greater than 30 mm and central necrosis, intermediate for perinodal fat stranding, lobular contours, and absent perinodal fat planes, and lower for matted conglomerate nodes and irregular nodal margins. In our discussion, the clinical impact of studying extranodal extension in patients with HPV-positive oropharyngeal squamous cell carcinoma is important because these patients are often treated with transoral robotic surgery followed by radiotherapy. However, the detection of certain pathologic findings, including E&E or positive resection margins, are indications for adjuvant chemoradiation instead of adjuvant radiation alone. Therefore, one can imagine the impact of accurate pretreatment detection of E&E on imaging. And though many imaging features of E&E have been studied, they seem to have variable success in predicting E&E. Our study, in the hopes of identifying key characteristic features, again produced variable outcomes in terms of sensitivity, specificity, predictive values, accuracy, and inter-observer agreement. Some of our limitations included a small cohort of 75 patients and a panel of 2 imaging readers. In summary, inter-reader agreement for the 7 features was only moderate even with modest training. None of the previously published CT features associated with E&E proved to be replicable in the study. However, this leaves way for future studies that may include larger patient populations, include more expert readers, as well as have more pre-evaluation training. Additionally, other avenues of detecting E&E via artificial intelligence or machine learning may have a role and is something that we plan to explore in future studies. And that concludes our presentation. Thank you all again for your time and for listening. I've included my email below. Please feel free to contact me with any questions, comments, or suggestions. I'd love to hear from you.
Thank you so much to everyone who participated in that session. I believe that's our last paper. I think we have time for at least one question from the last presenter, if the author is online. There's been a lot of activity in the chat. We were wondering why you chose specifically to do HPV positive patients in that session rather than HPV negative. I think there's been a lot of answers, but maybe you could just expand on that.
Yeah, thank you for your question. I think there had been a lot of studies initially focusing on HPV negative cancer. And it is true that the prognosis of HPV positive cancer is not as affected by E&E status. However, the treatment algorithm, I think at this point, the standard treatment is for those patients with localized HPV positive cancer to undergo TORS. However, if they were found to have positive E&E or were found to have positive
margins on excision, then they're subject to more intensive treatment with post-adjuvant chemoradiation compared to just radiation alone. So that sort of alters their treatment algorithm.
Great, thank you so much. And I believe that concludes our session for today. I did record some closing comments, but I can also just state them here. I want to thank all of the authors for their submissions and their recordings. I want to thank my co-moderators, and I'm so impressed with the attendance. I think this is like the most active and interesting and heated debate on a scientific session I've ever seen at a meeting. So I don't know. I think maybe we should do this virtually in the future.
Yeah, I don't think we should ever go back to the other way. I think this is
it's got to be an attendance record for this meeting's scientific presentation.
Highly impressed. So thank you everyone for joining us this afternoon, and please stay tuned for the rest of tonight, including the business meeting as well as the fabulous game show hosted by Dr. Claudia Kirsch.
All right, everybody. Bye-bye.